can start, doctors.
A very warm welcome to all the esteemed members of GDP. It's my pleasure to welcome Dr. Roohparvar Khan. Dr. Roohparvar Khan has completed her BDS from Al Badr Dental College, Gulbarga, and MDS from Nijalingappa Dental College, Gulbarga in the year 2022 in periodontology and implantology. She is currently practicing in Mumbai at Syed Dental and Implant Center. She holds her expertise in the field of basal implantology, sinus augmentation protocol, nasalis pterygoid zygomatic protocol for implant placement. She has published an article on surgical management of peri-implantitis assisted with photoablative surgery in International Journal of Dental Sciences and Innovative Research. Today, Dr. Roohparvar will be sharing her insights on crown lengthening and biological width modification, which is a crucial area for our continued learning and development. Without any further ado, please help me welcome Dr. Roohparvar Khan, and inshallah, I'm sure we will be enriched by this webinar. Thank you. Over to you, Dr. Roohparvar Khan.
Good morning, everyone. I am heartily thankful to Global Dental Professional Platform to give me the opportunity to present a webinar on the current topic. So I'll be presenting my webinar on crown lengthening and biologic width modification. Hope I'm audible and my screen is clear. So my topic is crown lengthening and biologic width modification. So to begin with, periodontal health, as we know, is the sine qua non. That means it is a very essential consideration when we are restoring a tooth with crown and bridge, or we are placing the implants for occlusal rehabilitation. So to achieve the long-term therapeutic target, good comfort, good function, and treatment predictability, longevity and maintenance of the treatment, considering the periodontal health is a very important factor. The rationale of periodontal therapy is to ensure stable gingival margins before tooth preparation, to provide for adequate tooth length for retention, access for tooth preparation, impression making, and giving restorative margins in anticipation of restorative dentistry, and also to correct the occlusion prior to any restoration for long-term stable results and good comfort of the patient. In the present scenario, patient is very much conscious regarding the aesthetics also. So to provide good function and good aesthetic, it is very important to consider periodontal health before proceeding with the restorative dentistry. The concept to achieve good periodontal health, we have to consider certain factors before giving the restoration. That is whether the gingival margin are according to the biological width, is it matching with the biological width, and the dimensions are accurate or not. So if there is any alteration in the dimension of gingival margin or the width of the attached gingiva, we have to go for certain aesthetic procedures which are known as crown lengthening procedure or apically displaced flap, etc. So the concept of crown lengthening was first introduced by D.W. Cohen in the year 1962. So what is crown lengthening? Before understanding crown lengthening, we should understand the factor that crown length is of two types. That is clinical crown length, which is visible clinically, and the biologic crown length. That is the length from the occlusal tip or the incisal margin to the CEJ. So the surgical procedure designed to increase the extent of supragingival tooth structure for restorative or aesthetic purpose is known as crown lengthening. So where the crown lengthening is exactly indicated? It is indicated in the treatment of subgingival caries, crown or root fractures, or altered passive eruption. You can see in this figure, the patient is suffering from the cervical caries. So without doing crown lengthening, we cannot give proper restoration in this case. So here we can see, to excavate the caries properly and to give proper restoration, first we have to do crown lengthening. We have to expose the caries surface, that is the decayed surface, then we can give the proper restoration. And to produce a ferrule effect of the restoration, this is for a proper prosthetic consideration, to access a perforation in the coronal third of the root. That is, while doing root canal procedure, if there is a access hole in the bifurcation area, or we have got perforation, we can expose the coronal third of the root and we can locate the furcation. Then we can go ahead with the root canal procedure to relocate the margin of the restoration that are impinging on the biological width, and for the aesthetic purposes. Where we have short teeth and patient suffers from a gummy smile, we can go for crown lengthening procedure. Then we can go ahead with the restoration to give a good aesthetic result. Apart from consideration, there are certain contraindications for crown lengthening, which include inadequate crown to root ratio, non-restorability of carious tooth structure, then where we have aesthetic compromise. Suppose patient have a smile which has very long length of the upper central incisor. So in that case, crown lengthening is contraindicated. There we have to go for the orthodontic intrusion of the tooth. Then in the areas where we have high furcation, if we do crown lengthening here, then there will be excess food lodgement, which will result in periodontal damage. Then inadequate predictability, that means the prognosis of the case is not good and still we are going for crown lengthening procedure, it is not indicated. And where we have tooth arch inadequacy, then compromise of adjacent periodontium or aesthetics, then insufficient restorative space, or non-maintainability of the patient. That means if the patient has very poor oral hygiene, or the patient is prone to systemic conditions, in such conditions, crown lengthening is not indicated unless the patient is very well educated regarding the periodontal health and he is ready to maintain the periodontal health. So what are the things which we should evaluate before proceeding with the crown lengthening procedure? There are basically two factors that are considered. First is the clinical evaluation and second is the radiologic evaluation. In clinical evaluation, we have to see how much is the sulcus depth. Like normal sulcus depth is 3 mm. So if the sulcus depth is more or less, so which procedure should be proceeded with the following sulcus depth? Then what is the biological width of the tooth or around the implant? Then what is the osseous crest? Whether it is a high crest patient, normal crest patient, or low crest patient, which will be explained in detail in the following slides. Then whether the tooth is pulpally involved. Then what is the apical extent of the fracture of the tooth? Then what is the gingival health and the amount of attached gingival tissue? Then loss of mesodistal or occlusal space, then anticipated final margin placement, and what is the lip line of the patient. What is the lip line at the rest and at the smiling. Then in radiographic evaluation, we have level of alveolar crest, again apical extent of the fractured tooth, then pulpal involvement, furcation, crown root ratio, and root trunk length. So basically, crown lengthening is an aesthetic periodontal surgery. So criteria for periodontal surgery include, before proceeding to any periodontal surgery, the criteria, this criteria should be considered. That is, the surgical site is free of plaque, calculus, and inflammation. Free of plaque means it is not possible to maintain 100% plaque-free site, but we should try the maximum effort to maintain the surgical site free of plaque. That is doing scaling and root planing before the procedure, and putting the patient on oral hygiene practices 1 week prior to surgery. Then whether the tissue has adequate blood supply. Then what is the anatomy site of the recipient, whether we are doing the crown lengthening on the anterior region or the posterior region. Then stability of the grafted tissue. Then while doing surgery, we should focus on doing minimal traumatic surgery. There should be no excess removal of the tissue or very long-term surgical procedure or any excess trauma to the surgical site. All these factors will delay healing if we do not give importance to these factors. The most important factors which are considered before doing crown lengthening is, what is the lip line of the patient, whether it is high lip line or low lip line, what is the position and shape of the gingival margin, and whether the patient has any gingival discrepancies or there is any excessive gingival growth. Lip line means ideal lip line is considered when the patient is at rest or when the patient is smiling. The upper lip should cover the middle third of the upper incisors. And position and shape of the margin signifies that whether the patient has high crest, low crest, or uh, uh, average crest of the gingival margin in relation to the alveolar bone. Gingival marginal discrepancies means whether the patient has gingivitis, periodontal disease, or any gingivitis is inflammatory or fibrous gingival overgrowth, and excessive gingiva, which also includes whether it is orthodontically misplaced arch, or the patient has any ortho issues like excessively exposed gingiva, which is naturally, or the patient has low maintenance profile, or the patient is subjected to any systematic disorders and the patient is taking like hypertensives, or any neurological manifestation is there in the patient which causes excessive gingival overgrowth due to gingival hyperplasia, fibrous gingival hyperplasia. So all these factors should be considered before proceeding with the crown lengthening procedure. And also the midline of the lip, midline is also considered to give proper aesthetic results. And what is the occlusal plane of the teeth for a good aesthetic margin and for giving the zenith of the gingiva. As I explained, excessive gingival display may be because of excessive maxillary overgrowth or the tooth malposition or delayed eruption of the gingival margin or delayed migration of the gingival margin to its original place, which is because of the delayed migration of the junctional epithelium also. This includes any hormonal discrepancies or malformations. So this is another consideration. We have to consider the tooth length also, and what is the zenith of the gingiva, and what is the position of the gingival margin with respect to the tooth prescribed to the crown lengthening procedure. For example, the crown height of the canine is 11 to 13 mm. Also, the central incisor is 11 to 13 mm, and the crown height of the natural crown height is 10 mm. So there is 1 mm of difference of gingival margin with the central incisor and canine. And occlusally, when we see, it is 1 to 2 mm of the difference in the occlusal plane. So when we are doing crown lengthening, we are not supposed to give the same gingival margin to the lateral incisor or to the central incisor. Okay. Central incisor has higher gingival margin when compared to the lateral incisor. There should be a difference of 1 mm when we are doing crown lengthening procedure for canine and lateral incisor, or for lateral incisor and to central incisor. So there are two types of gingival margin. Okay, type 1 and type 2. In this type 1 and type 2, again we have subgroup A or B. In type 1 gingival margin is placed incisal or occlusal to the CEJ. In type 2, dimension from the gingival margin to the mucogingival junction falls within the normal range. In this type, all of the gingiva is located on the anatomic crown with mucogingival junction located at the level of CEJ. Then subgroup A includes alveolar crest. Cemento-enamel junction relationship corresponds to the 2 mm distance. Subgroup B is alveolar crest is almost at the level of CEJ. That means in subgroup B, alveolar crest has a good predictability and it gives stable results. So this is the diagrammatic representation. We can see in type 1A, CEJ to alveolar crest is greater than or equal to 2 mm. In type 2A, it is CEJ and alveolar crest is greater than or equal to 2 mm and mucogingival junction is at distance. In type 2B, there is less distance between CEJ and mucogingival junction. That is, it is less than 2 mm. Now, what are the surgical procedures indicated according to the type of the gingival margin? Type 1A, only gingivectomy is considered because we have sufficient distance between the gingival margin and the alveolar crest. And here 0.5 mm restorative margins should be given 0.5 mm subgingival, because there is sufficient space between the gingival margin and the alveolar crest. So there is no question, or there is no doubt of developing gingivitis or periodontitis after restorative dentistry in type 1A. Whereas in type 1B, flap procedure is considered, that is apically displaced flap. In type 2A, again, flap procedure without osseous surgery is considered because the distance between the gingival margin and the alveolar crest is less here. Whereas in type 2B, flap procedure, that is apically repositioned flap without osseous surgery is considered, because the distance between the gingival margin and the alveolar crest is less in type 2B. Whereas in type 2A, the distance between the gingival margin and the apical crest of the alveolar bone is increased. So flap procedure with or without osseous surgery is considered. Now, considering the biological width, the original concept of biological width arises was given by Gargillo, Wentz, and Orban in the year 1961, and they considered it to be as the value of biological width as 2.04 mm. Why is biological width essential? It is essential for the preservation of periodontal health, removal of irritation that might damage the periodontium when we go ahead with the restorative dentistry. So Gargillo et al. In 1961 suggested that when we see histologically, the average histological width of connective tissue attachment is 1.07 mm. And the mean average length of epithelial attachment is 0.97 mm. And the sulcus depth is 0.6 mm. So biological width will be the combination of connective tissue attachment and junctional epithelium, which is, when we add all these measurements, we will get it around 2.04 mm. This is for a natural tooth. But when we consider the biological width for implant, it is 3 mm, which I will be explaining in the further slides. So Coes and Spear pointed out that the dentogingival complex is 3 mm facially and 5.5 mm interproximally. They noted that the height of interdental papilla can only be explained by increasing the probing of the bone. Baker and colleagues also defined variation of gingival scalloping as flat and scallop. So which means that biological width is not a fixed value. It differs with a difference of 0.5 mm according to different authors. Then Maynard and Wilson, they divided the periodontium into 3 dimensions to properly understand the biological width. That is superficial physiological, crevicular physiological, and subcrevicular physiologic. So the subcrevicular physiologic space is analogous to the biological width according to Maynard and Wilson. So after all these studies, Coes in 2000 suggested that biological width can be categorized based on 3 broad categories on the total dimension of attachment and depth of the probe. So he classified it as normal crest, high crest, and low crest. So how this normal, high, and low crest is classified? It is classified based on the mid-facial measurement, proximal measurement, and occurrence of the in what people, how much percentage of this measurement is ranging. So mid-facial measurement. Normal crest is considered when the mid-facial measurement is 3 mm. High crest is considered when the mid-facial measurement is less than 3 mm, and low crest patients are considered when the mid-facial measurement is greater than 3 mm. Then in normal crest, proximal measurement varies from 3 to 4.5 mm. And in high crest, proximal measurement, there is one area where the crest is seen more often in a proximal surface adjacent to the edentulous site. when we have a edentulous site, there the extent of proximal measurement is more as compared to the dentulous site. And here also it is less than 2 mm considered. So the occurrence is mostly among the normal crest patient. That is, most of the patient presents a mid facial measurement of 3 mm. That is approximately 85% of the time of the gingival tissue, and it is stable. Then high crest patient is seen in 2% of the time, and low crest patient approximately 1%. In this figure, we can more clearly understand what does normal crest, high crest, and low crest indicates. See, this is the mid facial measurement. Okay, this is 3 mm. That is from the alveolar crest. And interproximally, we get 3 to 4.5 mm. From alveolar crest to the tip of the marginal gingival, interdental papilla. This is interproximal measurement, which is 3 to 4.5 mm in the normal crest patient. Whereas the mid facial measurement, that is from the crest of the alveolar bone to the gingival margin, is 3 mm. This measurement is considered as normal crest. In high crest patient, we see less than 3 mm of the interproximal measurements, okay, and less than 3 mm of the mid facial measurements. So in this case, it is not possible to place an interclavicular margin because the margin will be too close to the alveolar bone, resulting in biological width impingement and chronic inflammation. In normal crest, we can place a margin no closer than 2.5 mm of the alveolar bone. So therefore, a crown margin is placed 0.5 mm subgingivally, which tends to be well tolerated by the gingiva. In low crest patient, these patients are more susceptible to gingivitis and periodontitis when the crown margins are placed subgingivally. So it is better to avoid subgingival restorations in low crest patients. So the mean biological width which was calculated was 3 mm. Another authors which also suggested that is Padbury et al. In 2003, they stated that these dimensions can vary considerably with epithelial attachment ranging from 1 to 9 mm, although dimensions for connective tissue attachments are generally less. Then Rosenberg et al. Suggested a biological width of 3.5 mm. So what is the importance of biological width? In contemporary practice, it significantly reduces the risk of periodontal attachment loss induced by subgingival restorative margins. It also serves to protect against invasion from bacteria and other foreign materials. And moreover, results from an animal investigation involving histological evaluation indicated that restorative margins impinging on osseous crest may cause bone resorption. So while maintaining the restoration, while giving the restoration in a natural tooth, we have to always consider that 0.5 mm subgingivally when we are placing the restorations, there should be at least a minimum gap of 2 mm between the restorative margin and the alveolar crest to maintain the oral hygiene and to maintain the health of gingival and periodontal tissues. If we do not maintain this length of 2 mm or 3 mm, so what are the clinical findings we see and what the patient complains if there is violation of the biological width? There is chronic pain and progressive gingival inflammation of around the restorations. There is bleeding on probing. Then there is localized gingival hyperplasia with minimal bone loss. Then we see gingival recession and pocket formation and clinical attachment loss and alveolar bone loss over the time if this biological width is not maintained. So clinically, how we can find whether biological width is maintained after giving the restoration? There is a procedure called as bone sounding or transgingival probing, which was given by Vivek et al. In the year 1994. So this procedure can be done under local anesthesia. The biological width can be identified by probing under local anesthesia to the bone level, referred to as bone sounding. If this distance is less than 2 mm at one or more locations, a diagnosis of biological width violation is confirmed. By radiographic interpretation, we have to take parallel radiograph to diagnose whether the biological width is violated or not. I will show you a pictorial presentation of how to, we have to take a probe and we have to walk the probe like this, Williams probe. While walking the probe, first we have to see how much, what is the sulcus depth of the probe. And if the patient complains of the probe and you see irregular margins and there is bleeding, then it is the confirmation of violation of biological width. This procedure is called as bone sounding and it is done under local anesthesia. Since the patient is under pain because of biological width violation, so it is necessary to give local anesthesia. Otherwise, patient will be very uncomfortable and he will pain more pain if we do it without anesthesia. So, Coes in 2000, he proposed 3 categories of biological width based on total dimension of attachment and sulcus depth following bone sounding measurement. Again, Coes also explained it in the 3 way, that is mid facial measurement. As I explained previously, it should be 3 mm and proximal measurement should be 3 mm to 4.5 mm in normal crest patient. So normal crest occurs approximately 85% of the time, and in these cases, gingival tissue tends to be stable for a long time. Therefore, a crown margin which is placed 0.5 mm subgingivally tends to be well tolerated in normal crest patient. In this diagrammatic representation, we can see the mid facial measurement is 3 mm and interproximally it is 3 to 4.5 mm. So in this case, we can safely give a subgingival margin of the restoration of 0.5 mm. When we give a margin of 0.5 mm, there is still 2.05 mm of the space left, which is safe and well tolerated by the patient after giving restoration. So this is a high crest patient. High crest means bone is at a very high level with respect to the marginal gingiva. You can see there is very less space. Okay, the mid facial measurement here is less than 3 mm, and interproximally also it is less than 3 mm. So this high crest patient is well diagnosed when there is an adjacent edentulous space. It is very difficult to diagnose high crest patient in a dentulous area because of the tight contact of the teeth. So high crest less than 3 mm, and here the subgingival restoration is less tolerated as compared to the normal crest. Low crest. Low crest means the alveolar crest is at a certain long distance when compared to the gingival margins. This distance is more than 3 mm. So when we are restoring such cases, we have to do surgical crown lengthening here to reduce the amount of gingival margin. If we do not reduce the gingival margin in low crest patient, there is more chances of food lodgement because of the more space area, because of the increased sulcus depth. So in this case, crown lengthening is indicated or gingivectomy along the gingivoplasty is indicated to reduce the distance between the alveolar crest to the gingival margin. Here also subgingival restorations are well tolerated. But there is a disadvantage in low crest patient, that is when the retract, why? Because gingival margin is the tissue thickness is very thin here, and when we place retraction cord while preparation of the subgingival margin, the attachment apparatus is routinely injured. So as the injured attachment apparatus heals, it tends to heal back to a normal crest position, resulting in gingival recession. See, there is a, in low crest patient also, it is again divided into stable patient and unstable patient. In case A, we see there is a very long distance between the crest of the alveolar bone to the gingival margin. So such patients are classified as unstable patients. Hello, I am audible?
Yes, doc. You can please continue. We can able to hear you here.
My screen is visible?
No, your screen is blanked out.
Hi, doctor. Stop
Just
screen sharing and reshare again. Reshare again. Stop it and reshare again. Quickly. Yeah, we can see your slides. Come back to the slide which you want.
okay.
Yeah, please continue.
Sorry for the disturbance. So basically, we have to consider three rules when we are placing the margins. So if the sulcus probe, that is the sulcus depth is 1.5 mm, the restorative margin should be placed 0.5 mm below the gingival crest tissue. If the sulcus probe is more than 1.5 mm, the restorative margin can be placed in half the depth of the sulcus. And if the sulcus is greater than 2 mm, that is low crest patient, you have to perform gingivectomy, and then we have to give the margin subgingival. And the sulcus depth should be maintained 1.5 mm, then give the margin subgingival. Now, the another important factor which we should consider before giving the restoration and for maintaining the biological width is the ferrule length. A ferrule is nothing but a metal ring or cap intended for strengthening the restoration. So the glossary of prosthodontic terms defined it as ferrule of metal band or ring used to fit the root or crown of a tooth. So Sorensen and Engelmann redefined the ferrule effect as 360-degree encirclement or a metal collar of the crown surrounding the parallel walls, extending coronal to the shoulder of the preparation. This ferrule effect is given to strengthen the restoration and also to maintain the plaque-free margins. Now considering the biological width around the implants, when we consider the biological width which natural tooth and implant, there are two basic factors which is considered. Most important difference between periodontal and peri-implant tissue is here the periodontal structure runs perpendicular to the tooth, and in implant the fibers runs from crest parallel to the implant surface. So peri-implant biological width is composed of the sulcus depth, supracrestal epithelium and connective tissue component. While maintaining biological width around the implant, some other factors has to be considered, amongst which the most important five factors are: what is the kind of surgical technique used, what is the loading time around the implant, what is the abutment material used, what is the implant structure and position, and whether the implant is an immediate implant or it is the post extraction implant, like we have given some time after extraction. So while considering the surgical technique, we have to see that it is a less traumatic surgery, because if the surgical technique is more traumatic, there is more amount of bone loss, and in future there is more predictability of developing peri-implantitis because of the loss of periodontal structure. Loading time. The approximate loading time for a two-stage implant technique is minimum of 4 to 6 months in a healthy individual. And if the patient is a systematic individual or there is any bone deformity, we have to give more loading time, because if we do hurry in the loading time, there are more chances of development of peri-implantitis. Loading time, more the loading time, good is the osseointegration around the implant. This loading time is considered when we are placing conventional implant. Loading time is not considered in basal implant, because in conventional implant we are giving the restoration for when considering when we are osseointegrate, when we are considering the osseointegration. In basal implant it is osseofixation, so loading time is not considered here. Next is the type of the abutment material is used. It is very important to have a good prosthetic consideration while restoring the implant. If the restorative surface is rough, and if the quality of the abutment material is not good, and if the margins are not maintained properly, it leads to more plaque accumulation, which leads to peri-implantitis and implant failure. Then what is the implant structure and position? That means implant structure means whether it is a screw retained or cemented implants. Here, what factors we have to consider is if the abutment height is 4 mm, 4 mm or more, then we can give cemented implants. If the abutment height of the implant is less than 4 mm, then we have to give screw retained implant, because cement retained implant will not work if you don't have the good abutment height. And what is the position of the implant, whether we are placing the implant anteriorly or we are placing the implant posteriorly. If we are placing the implant anteriorly, we can load at the earlier level, because there are less occlusal forces here, and we can slightly give the restoration free of occlusion. But when we are loading the implant posteriorly, when we are giving the restoration, there we have heavy occlusal forces, so we have to give proper time for osseointegration, then only restoration is considered. Then whether the immediate post implant is placed immediately after extraction or it is a delayed case. So after considering all these factors, we have to consider biological width around implant also, that is 3.08 mm. So when we consider the natural tooth and the implant, the difference in biological width is around 1 to 1.05 mm. That is, the biological width is more around implant as compared to the natural tooth. Here, because of the loss of periodontal structure while placing the implant, while doing ostectomy and all, we will have some amount of bone loss. Hence, biological width is more around the implant. So now, what are the procedure to increase the crown length? Basically, crown lengthening is done by a surgical procedure only. In surgical, we have gingivectomy. Gingivectomy, again, in these three types are there. Gingivectomy, that is conventional gingivectomy, that is cutting of the gingival margin with the scalpel or blade. Another is we can use diode laser. Next is we can use electrocautery. Then we have surgical extrusion using periodontal with the internal bevel gingivectomy with or without ostectomy, or apical positioning of the flap with or without ostectomy, or it is a combined, that is surgical and non-surgical, that is surgical combined with the orthodontic treatment. So the basic procedure of gingivectomy include, first we have to give the anesthesia to the prescribed area. Then pocket height is measured with the pinpoint marker. Then the incision should be beveled 45 degree to the tooth surface. remove the excess gingival tissue, carefully curate the granulation tissue, then the remaining removal of the calculus and necrotic cementum. Then we have to cover the area with the surgical pack. Here also there is a controversy whether we should give a surgical pack or no. So the factor which is considered whether we should give a surgical pack or no here is we have to see the patient. Whether if the patient is well educated, he has a good level of understanding of the medical issues, then you can give surgical pack explaining the patient that there will be food lodgement and accumulation around this surgical pack area. So you maintain a good hygiene, use a good mouth rinse. Surgical pack will work good here. If the patient is uneducated, if he cannot understand the language, please avoid giving surgical pack. If we give surgical pack in an uneducated patient, there will be more accumulation of plaque and debris in the area, which will further lead to inflammation. So in cooperative patient, please go ahead with the surgical pack. The patient where patient does not have a sense of understanding, please avoid surgical pack. That was about the conventional gingivectomy. Now laser. So the routinely used laser here is a diode laser, which was introduced in the year 1980, which is a soft tissue laser. It is used in continuous wave or gated pulse mode. The watt power used can be 5 to 10 watts. Okay. And the range of light used is here is 800 to 980 nanometer. Another laser which can be used is ND-YAG laser. With ND-YAG laser, the rate of heat generation is higher. So it is better to use the soft tissue laser because there is less heat with the diode laser, and we can perform the surgery in a controlled way. So what is the advantage of laser crown lengthening as compared to the conventional crown lengthening procedure? With laser, we have relatively bloodless surgical procedure and the ability to coagulate, vaporize or cut the tissues, and there is sterilization of the wound site here. Laser itself sterilizes the wound site, so we do not need antibiotic therapy. Then there will be minimal swelling and scarring. There is little mechanical trauma. Then there is reduced surgical time. Then it is high patient acceptance. Since it is the time is reduced, there is a bloodless field, so the patient acceptance is high. And there is reduced post-operative pain. The only disadvantage of laser is it is a high cost procedure. Electrocautery. This is again a commonly used alternative to surgical excision of the soft tissues. It involves the use of high electrical energy transmitted to the tip of the instrument in the form of heat generator, and it will cauterize the tissue. Here also we should take the caution to avoid excessive heat application to the tissues. Otherwise, it will cause necrosis or cementum burn. Next is crown lengthening using periodontal. Here also it is almost same like as we do with the conventional gingivectomy with slight modification. Here also local anesthesia is given. Then the blade of the periodontal is placed in the periodontal ligament space and manipulated in a walking motion to luxate the tooth without inducing the surgical trauma. That means we are cutting the periodontal fiber slightly. Then the tooth is extruded to the clinical position using a hemostat. Like while extraction, we extrude the tooth. It is like the same way with the help of periodontal fibers are initially cut. Then we will extrude the tooth slightly. After extrusion, slight suture, simple interrupted sutures are placed and periodontal pack is given. Then suture removal will be done after 10 days. And final restoration is placed after 2 months after complete periodontal healing and the tooth position is gained. The difference between conventional gingivectomy and crown lengthening with the periodontal is that in conventional gingivectomy, we will cut only the excess gingival tissue. Whereas crown lengthening with the periodontal involves a special instrument which is called as periodontal. As you can see here, this is a periodontal, a blade-like sharp instrument, and with this instrument only slightly the tooth is extruded to increase the crown length. Then final restoration is placed after 2 months. This is a diagrammatic representation of how the crown lengthening is done. Crown lengthening in a multiple teeth in a quadrant. Okay. Here there was less than 3 mm of the soft tissue. So crown lengthening is done and it is apically placed, apically repositioned flap here. You can see more clearly in this picture. This is a diagrammatic representation of how apically repositioned flap procedure is done to increase the crown length. First, circular incision is given and the flap is raised. Okay, after flap raising, we will give vertical incision to expose the area more properly. These are two vertical incisions given here. Then bone recontouring is done with a carbide burr along with saline irrigation. You can see the difference in crown length here before bone recontouring and here after bone recontouring. Then after bone recontouring, flap is placed back, sutures given, and the restoration is given after 2 to 6 months as per the healing of the patient. The last procedure is combined, that is surgical and orthodontic procedure. So in this procedure, there are again two types, slow eruption and rapid eruption. In slow eruption, we forced eruption is done followed by minor osseous reduction. Here forced eruption combined by only fibrotomy. In slow eruption, there is osseous resection also. That is slight reduction of the alveolar crest is done in slow eruption. Whereas in rapid eruption, where we have to hasten the procedure, only forced eruption and combined by fibrotomy is done. That is the parallel fibers, supracrestal fibers which are around, surrounding the tooth. These are more prone for the these are more supracrestal fibers. Supracrestal fibrotomy is done because these fibers are more rigid and they are more prone to recurrence of any condition. So supracrestal fibrotomy is done followed by forced eruption. So again, in non-aesthetic areas, the site should be re-evaluated after 6 weeks, 6 weeks post-surgically prior to restorative procedures, as I explained earlier. That is, after crown lengthening, any surgical procedure, restoration should be postponed for at least 6 weeks to maintain good periodontal health. In aesthetic areas, longer healing period is recommended to prevent recession. WISE recommends 21 weeks for soft tissue gingival margin stability. Therefore, a restoration should be initiated after 4 to 6 months. That means before giving final restoration, you have to give provisional restoration for 4 to 6 months. Then once 4 to 6 month period is elapsed, then we have to give final restoration to give good marginal integrity of the restoration. Shobha et al. In a study on clinical evaluation of crown lengthening procedure has concluded that biological width can be re-established to its original vertical dimension along with 2 mm coronal to the tooth structure at the end of 6 months. That is, according to Shobha et al., at least we should give a 6-month period time after crown lengthening procedure for proper integrity of the gingival margin. That is, gaining of 2 mm length between the gingival margin and alveolar crest. It takes minimum of 6 months according to Shobha et al. If we hurry or hasten the final restoration without giving proper time to heal the periodontal tissues, in future the patient will face gingivitis, periodontitis, and again there is loss of periodontium and there are chances of tooth mobility. So we have to maintain a proper timing of at least 4 to 6 months to proceed with the final restoration. So after 2 or 3 weeks post-surgery period, temporary crowns can be used until there has been full healing. Before tooth restoration, the gingiva should be healthy without any sign of inflammation. And we have to consider the measurement also. If gingival sulcus is 1.5 mm or less, the margin of restoration should be given 0.5 mm subgingivally. If the gingival sulcus is 1.5 to 2 mm, the gingival margins are given 0.7 mm subgingivally. If the gingival sulcus is 2 mm, especially in the aesthetic area, then the gingivectomy is recommended and the restoration is placed 0.5. So the conclusion is, although individual variation exists in the soft tissue attachment around the teeth, there is general agreement that a minimum of 2 mm should exist from the restorative margin to the alveolar bone, allowing for 2 mm of biological width space and 1 mm of the sulcus depth. So to conclude with the webinar, again, we will go ahead with the revision. That is, the average biological width is 2.04 mm, that is average of 2 mm. And the distance from the alveolar bone to the crest of marginal restoration is average is 3 mm. The ferrule effect which should be given is 1.5 to 2 mm. And when deciding to place margin, keep it subgingivally based on the sulcus depth rule. Thank you. This is the gross representation of how gingivectomy is done with the conventional procedure, that is with the blade. Here we can see in the excessive gingival display. So after measuring the sulcus depth, we have to, with the help of a pocket point marker, we have to mark the margin which is to be resected. Then we have to cut. Then after conventional gingivectomy, we can see the increase in the crown length. Thank you.
Thank you, Dr. Roohparvar, for your incredible, insightful presentation on crown lengthening and biologic with modification. We thank you for taking the time to share your expertise with us. Now, coming to the question and answer session, anybody would like to ask any questions? Okay, Dr. Roohparvar, I do have few queries. Regarding, can you please elaborate on the type of gingival biotype on crown lengthening procedures?
Basically, there are two types of gingival biotype, thin and thick biotype. So in thin biotype, there are more chances of gingival recession. So we have to give more importance of maintaining the proper gingival hygiene. And the important consideration should be considered that there should be no excess tissue removal when we are proceeding with the surgical gingivectomy, because thick gingival tissue will recede more easily as compared to the thin gingival tissue, thin gingival tissue will recede more easily as compared to the thick biotype, because there are less collagen fibers in that, and there is shrinkage of the tissue.
And one more query what I have is biological with crown lengthening around the implants. Is it possible? And if yes, what are the considerations?
Crown lengthening around the implants, actually there is no gingival hyperplasia around the implant. There is only inflammatory hyperplasia. If at all inflammatory hyperplasia occurs, we have to go with the cauterization or with the laser. I had published one article on this. We have got a similar case where the patient, he has undergone implant placement 2 years prior, and after 2 years, he was getting inflammatory gingival condition around the implant, and the implant was mobile to 1 to 2 mm. Then we opened the flap. We removed all the inflammatory tissue around the implant, and after applying tetracycline application and laser therapy, the patient was stable. So as such, there is no fibrous hyperplasia around the implant. Patient can have gingival inflammation around the implant, but it is minimal inflammatory inflammation.
And you did mention about the provisional restorations to be given after crown lengthening procedures. So, are there any particular guidelines or considerations for the provisional restorations also while giving immediate post crown lengthening procedures?
I had mentioned one slide, madam. In that it is, I mentioned that we have to wait for a minimum period of 4 months before giving a final restoration to maintain the proper marginal integrity.
I'm asking not about the final restoration, about the provisional restorations.
I need to learn that.
Okay. So we come to any more questions to be asked? If not, we can conclude the session for today. Thank you, Dr. Roohparvar and Dr. Gausia, ma'am, and the GDP for giving us this opportunity of learning today. Okay. Khuda Hafiz all of you.
Okay, thank you.